Hopefully you might be able to see me. I can't see me, but I'm sure you can. Anyway, there was a great lead in from Professor Wong's talk, because he is just up the road from me here in California. He's at the University of California, Irvine. I'm here at the University of California in San Diego. And we're going to talk about motivational strategies for busy healthcare professionals, as you can see from the title. I think it follows quite well from what you heard. Very similar, and I won't belabor this point from what you saw that was presented as a publication of Fan and Wong that was just presented. We know, whether we look at that particular database or here at the N. Haynes database, we see the same problem. I'm not going to belabor this point, but we really only have about a quarter of patients, slightly more than what we heard from the last talk, but similar, close enough, who are meeting ADA treatment targets. Again, it's a different registry. The vast majority of people here in the US are, as we like to say, not in a safe place, cardiometabolically speaking. I don't know what the numbers are like in India. I can't imagine they're any better, and they're probably worse. But the real issue that I'm going to focus on is, well, why? And what can we do about it? So when we think about poor cardiometabolic outcomes, let's first of all be clear that there's lots of different reasons this is going on. There's macroeconomic factors like poverty, right? If you can't afford your medications or can't afford treatment, you're in big trouble. There's the limitations of currently available tools in terms of what sort of medications might be available. You heard from Dr. Wong, Professor Wong, about SGLT2s and GLP-1s. They're not so affordable around the world. We know that sometimes the problem is healthcare provider behavior or clinical inertia, where people aren't really getting the sort of aggressive treatment recommendations that they need. And last on this list, but where we'll focus, is really about patient behavior. Sometimes our patients are disengaged from treatment, and we want to think about what that's about and what we can do as healthcare providers when we're working with our patients to make a bigger difference. Now, the common way to think about why is that so many of our patients seemed to be disengaged from their own diabetes self-management? Why is it that they don't take the medications that they're recommended, or how come they're struggling following a diabetes-friendly way of eating? The presumption often is that, well, it's their fault, and that we just simply need to shame them and blame them a little more until they start behaving. So I would ask you to consider another perspective on this, which is that when it comes right down to it, nobody is unmotivated to live a long and healthy life. Not any of you, not me, not our patients with diabetes. That's not really the issue. It's not a lack of motivation. The real problem that we understand from behavioral economics is simply that when the obstacles to self-management outweigh the perceived or possible benefits, people lose their oomph. They can be less enthusiastic or engaged. And we have a big problem in diabetes because there are a lot of obstacles, and a lot of the perceived possible benefits are in the distant future. And that's not as useful, because we as human beings tend to respond better to immediate positive incentives, and simply trying to avoid long-term complications down the road may not be as powerful a benefit as the day-to-day obstacles people face. So I've written a whole book about all the obstacles people with diabetes face, but let me just highlight two of the biggest ones, which we'll focus on when we think about interventions. One is that we have to understand that diabetes care, self-care, is a tough job. It is a challenging job. The day your patient first learned they had diabetes, it was as the universe said to them, congratulations, I have a new job for you to do. Oh, by the way, there's no pay, there's no vacations, and you get to do it forever. And we know that for any situation, changing habits for people, long-term, lifetime habits, is difficult. So when we're trying to encourage different ways of eating, different forms of physical activity, or any physical activity, that's tough for people because we are creatures of habit. So we have to appreciate that. Again, this idea of how challenging diabetes is, I think, was captured in a lovely paper I'm going to show you in a moment, where some of our colleagues said, what are all the tasks that are really required when you think about trying to manage diabetes actively? What are the things that you need to think about? What are the changes you need to make in your life? And they thought about, these researchers thought about it more than just diabetes. They said, what about people with chronic medical illnesses? What do they have to take on? What is the burdensome nature of their efforts. And they referred to what they came up with as what they call the taxonomy of burden, to try and capture all the work of dealing with a chronic illness like diabetes. And when they put that together in a figure, they came up with this. Now this, I guarantee you probably can't read. If I hold this as close to my face as I can barely read it because the print is so small. The items on this slide aren't important. What's important is just to illustrate something clear, which is that there's a lot to worry about, a lot to think about, a lot to be concerned about. It doesn't mean that diabetes management is not possible and that people
Dr.
can't
Polonsky, I'll just interfere once. Your screen is not visible. Are you sharing your screen with us?
Yes. It was
Okay, I thought you were
at
off
all.
slide. So you need to share your screen once more. It's not visible. We are getting to see you, we are getting to hear you perfectly, but your screen, your slides are not visible now.
Okay, were they visible before?
No, they weren't visible at all. I thought you were speaking without any slides. So you need to share your screen once more.
Okay, let's see how I can do that. I thought I was. Let's try it
Someone
again.
from the technical team help? Okay, I think it's visible now. It's perfectly visible now. Taxonomy of burden is the slide here. Okay.
Yeah. Oh, well, it's too bad you missed my best slides, but I'll go on.
Go ahead.
So you can see them now, though.
They are visible now. Please go ahead.
Okay. I will skip on because this isn't that important. Actually, I have a question. Can you still see them? No?
Yes, we can.
Yeah, we see better. Yeah.
You can see them now. Okay.
In fact, may I just interrupt? The slides
Sure.
that you thought were important and you missed, can you just run through them, go back and quickly show them and come back?
I'm kind of kidding you. I think I went over the details, actually. And there's more, so I'll just zip ahead. It's okay. The only point I wanted to make about this, just to show how much there's, and thank you for interrupting me, because that would have been, if you were just being polite, not seeing anything, that would have been pretty bad. But again, we want to appreciate that for diabetes management for any of our patients, whether we're talking about a type 1 or type 2. There's a lot we're asking people to think about and do. And as I was saying, diabetes management, successful diabetes management is possible despite all the effort and work, but we have to also appreciate for our patients, they have other things to worry about. They have other priorities and concerns and cares and responsibilities in their lives. So I'm gonna go back to my simpler slides now. That's one point that I wanted to highlight about what makes diabetes difficult. One of the big obstacles is a tough job. The other one is that often there's the perception that putting out the effort to manage diabetes day to day isn't worthwhile. And partly that's because of, well, a couple reasons, 3 in particular. One is that we're dealing with a disease, typically when we think about type 2 diabetes, that is a relatively invisible disease, and that which people, as well as often healthcare professionals, don't think of as an urgent disease. So we often hear people come to our office and make statements like this. Look, I'll start worrying about my diabetes as soon as something falls off. As soon as something terrible happens, then we're going to get serious about this. Again, that's a human nature issue. How do you engage people when you're dealing with a disease where high blood sugars don't hurt? High blood pressure doesn't hurt. High cholesterol, you can't feel it. That's part of this lack of worthwhileness. Another part is often there's a real sense of hopelessness, and perhaps you've seen this in some of your patients as well. People say things like this, what's the difference? This disease is going to get me no matter what I do. If you feel like diabetes is a death sentence, if you're doomed, it's not a big surprise. People might lose some significant enthusiasm about wanting to engage in following healthcare provider recommendations. And finally, the other major contributor is just a sense of discouragement. And here's an example from one of our patients who said, I did everything I was supposed to, and now you're telling me I have to take even more meds? And we know that actually with type 2 diabetes, odds are pretty good over the course of time, you are going to be taking more medications. You're going to be needing more because that's the nature of type 2 diabetes. It's not because you've done anything wrong. It's just how we know the natural history of type 2 tends to progress. At least it has so far. So I want to leave all that behind because our time is limited, and I want to get very practical, because the real issue and you all have limited time, is what do you want to do about this? how do we engage our patients who are seemingly disengaged? How can we make a difference? And so I want to go through a series of steps that we have found that are useful. I'm going to present some evidence for some of them, and where I can't, I'll be clear about that. So step number one is this: if there's nothing else, it's really important to assess what's going on. Now, we have a series of formal psychometric instruments we use to do that, but often there's no time in busy practice. And the easiest thing to do is to ask just a question like this. You know, Mrs. Smith, it's nice to see you today. Can you tell me one thing? What's one thing about diabetes that's driving you crazy? And I'm holding up this finger for that particular reason. I'm terrified Mrs. Smith might want to tell me everything. And I know if we do that, I'll never get out of here. Again, our time is limited. But can you tell me one thing about diabetes that's driving you crazy? Let's open that door at least a little bit. It's a real way to honor our patients. And it's a real way to engage them and let them know that we are concerned about them as humans and that to some degree we're on their side. And even if you don't solve whatever the issue is, fix the problem, you have changed things in such a way so that your recommendations are going to be heard differently just by honoring people in this way. So that's step one. And think about how you might ask this. Again, it's not, is there anything about diabetes that's driving you crazy? But can you tell me one thing that you really find that's challenging? You may think about it in your own words. It can be incredibly valuable. The second step is, of course, how you respond to that. There's no need to fix people's feelings if someone says, well, I'm sick to death of dealing with this disease. But what is important is to take a few moments and to listen and to acknowledge and to normalize what you've just heard. And so, for example, saying something like, look, you know, given the nature of diabetes, feeling this way is perfectly reasonable. And many other people feel the same types of aggravations that you're feeling. It's one of the reasons why we've seen with group medical appointments and other types of support groups how powerful they can be. Because when we provide people with an opportunity to get to meet each other and learn that some of their aggravations and frustrations and sense of despair about diabetes are shared by other people, it can make a big difference. But the key here, as we think about what the healthcare provider is doing, is again, engaging with their patient, at least for a few moments as a human, and trying to respond to them with some sense of respect and empathy. Now, that may sound like typical psychology, kind of something nice, but I really want to highlight how profoundly powerful this kind of intervention is. And to do that, I want to tell you about a study that was just published last year. It came from the UK. And in this study, they looked at about 600 patients with type 2 diabetes who had been diagnosed within the past year or so. And they surveyed these patients and asked them, so tell us about what your healthcare provider is like, your physician. What's your relationship like? And they specifically asked the individuals to rate their physician on these 10 questions. You know, how good was your healthcare provider? Making you feel at ease, listening you tell your story, really listening, being interested in you as a whole person, etc. But this idea of to what degree do you have this sense of your healthcare provider as someone who is empathetic and who is on your side? What's amazing about this study, the Dunbar-Miller study, is they then followed these people for 10 years. And after 10 years, they looked at, I would say, probably the most important outcome, which is mortality, and said, was mortality related to what these people had reported 10 years earlier about their relationship with their healthcare provider? And the conclusion was this, and I'm going to read it to you. In this 10-year follow-up of patients with newly diagnosed type 2 diabetes, those reporting better experiences of empathy in the first 12 months after diagnosis had a significantly lower risk, 40 to 50%, of all-cause mortality over the subsequent 10 years compared with those who experienced low healthcare provider empathy. So we're talking about something very powerful. Now, this study has never been replicated. This is new, but this is extraordinary, showing that this sort of, at least the perception of healthcare provider empathy, can have a very powerful effect on some of the most important clinical outcomes we can imagine in diabetes, like death. So consider that, and also consider, and I want to be respectful of those of you who are busy healthcare providers, because odds are good you may have a waiting room full of people outside, and I'm saying, well, spend some time and try to be empathetic with your patients and be a good listener. That can be a real conundrum if your time is limited. But it's important to at least give it a minute or so if you can, to let your patients know that even though you may not have much time, you do respect them and that you are interested in them, and you'll make what time you can to address and understand diabetes from their perspective, that it's more than just a numbers game. So that's step 2. Step 3 is this issue of making the invisible visible. And here's one of the ways in which we've tried to address that. This is a form we used in a project that we developed for one of the local healthcare systems here in San Diego, where for every patient, we would actually bring them together in small groups. We would develop this kind of a scorecard. So this is the scorecard for Molly. And we kept it very simple, just A1C, blood pressure, and LDL. You can see the second column were Molly's goals with her physician. And the third column are Molly's last numbers. Her last A1C was 8.7%. You can see her blood pressure, 125/75, and her LDL of 116. And then we accidentally, in this project, discovered something remarkably important, which was we then gave Molly a pen. And we asked Molly to put a check mark in the green zone, whether she thought she was in a safe place or not a safe place, or excuse me, safe place, and if she was in the green zone, or please put a check mark in the red column if she thought she was not in a safe place. So first you do it with her A1C, then blood pressure, and then lipids. And you can see, for example, under A1C, she put a check mark appropriately in the red zone because her A1C was, of course, significantly higher than where her target goal was. And what we were struck by was how powerful it was that it wasn't us telling Molly that she was in an unsafe place with her blood sugars. It was Molly telling Molly she was in an unsafe place. And that was much more powerful. So Molly would put that check mark in the red zone for her A1C and look at us and say, well, this is not okay. What are we going to do about this? It was a powerful way to try to make something that's barely invisible a little more visible. We know that A1C, blood pressure, lipids, this is our most underused motivational tools that can really make a difference in how we talk about it with our patients. You notice, by the way, the words we use. We don't say high or low or good or bad. It's safe or not safe or unsafe. We find that those words are not patronizing. They're not blaming or shaming. It allows us to be on the same side as our patients. Now, many of our patients, Molly, for example, might say, well, what does it mean to be in an unsafe place with my A1C at 8.7%, for example? And we'd say, well, Molly, it's kind of like there's a fire burning in your house. And the good news is we have most of the tools to put that out, but let's get to it. We think of the A1C for you, Molly, your blood pressure reading, your lipid reading, they're like smoke alarms in your house. And by checking them regularly and by talking about them, we can catch them before there's a big fire and put it out and avoid a lot of the destruction that can happen when this goes on. So it can be a very useful way, although images work differently in different countries. I can tell you that images of fire and big fires work very well here in California, where we have a lot of forest fires. But in other countries, we're going to have different imaging that will be better. So we want to make sure when we talk about people's numbers that we want to be non-judgmental, right? This is not about, I can't believe your A1C is so high. What did you do wrong? What's wrong with your cholesterol? You know, there are often good reasons. And so whenever possible, as odd as this may sound, we want to offer congratulations. And I'll give you an example of that. How we might talk to Molly about her A1C. Think of the two ways we might respond if we saw that 8.7%. On the one hand, we might say, Molly, your A1C is still too high. Don't you understand the consequences? Why aren't you working harder on this? But we could say it this way. You know what? It's great that you took the time to get your A1C done. The numbers haven't moved much since the last time you did this, which tells us that something different is needed. So we're ready to take action, but we can do that without blaming and shaming. And again, when we do that, it's not just nice, but it makes it easier for our patients to listen to us and hear us. So that's step 3. Step 4 is the importance of sharing the good news. We talked earlier about how despairing people and how hopeless often folks are with diabetes, often because they've seen bad things happen to people in their family, run into all the scary complications that we can imagine. What we find useful, this is something we often do in group systems, is we like to do true and false questions and engage our group. So this is the most one we've been using for decades. We'll say, true or false, diabetes is the leading cause of adult blindness, amputation, and kidney failure. Most people will agree, both patients and healthcare providers, that this is true. And then we go, well, no, it's false. It's really poorly controlled diabetes. It's the leading cause of adult blindness and amputations and kidney failure. And what's important to add is the corollary, which is that well-controlled diabetes is really the leading cause of nothing. And this is what we call evidence-based hope. We can invert some of the scary things that we're telling people. It doesn't mean we shouldn't talk to people about the risk of running into long-term complications, but we want to give them some realistic evidence-based hope. Now, a fact check. I don't mean to say that with good care, we can guarantee that you won't develop complications. But what all the evidence we've seen over the past few decades tell us is that with good care, odds are pretty good you can live a long and healthy life with diabetes. And that's the message our patients are desperate to hear, and it's profoundly motivating and engaging. Let me just give you one example of how we like to share this with patients. We have pretty interesting data for both for type 1 and for type 2. I only have, because the time's limited, I'll just tell you a little bit of the type 1 data. So when I present to groups of individuals with type 1 diabetes, I'll say, let's imagine we've had a big group of people who've had type 1 diabetes for 30 years. And after living with type 1 for 30 years, what percentage of these folks have run into the scariest complications? And I'll say, well, here's one healthcare system that actually did that study, and here's what they found. Starting on the left side of your screen, they found that after living with type 1 for 30 years, about 30% of the population already had severe vision loss or gone blind. The middle column, they found that more than 10% already had very significant amputations. And after 30 years with type 1 diabetes, well more than a third already had significant nephropathy. And when we show this to patients, they go, yeah, it's not a big surprise, might be what I suspect. But eventually someone says, why does it say 1978 on this slide? And I go, oh yeah, I forgot to tell you, this is really old data. You know, this is from a time when we didn't even have A1C tests and didn't have analog insulins and didn't even have good evidence that good control mattered. But then I can show you more recent data. And so we look at long-term outcomes from the DCCT or the DAYDEIC trial. That last data we saw was 10 years ago. But again, a large population of people who were in the intensive arm of the DAYDEIC trial, again, living with type 1 after 30 years, what percentage of that group had run into the same complications? And their numbers look like this. This always shocks people when you show that to them. That severe vision loss was less than 1%, amputations about 1%, nephropathy, not as good as it could be, but 6 or 7%. Things have changed dramatically over the years. Not that this is guaranteed. We know that the people in the DAYDEIC trial got very good, consistent, ongoing care over all these decades. But this is what's possible. And to put it in the words of one of our most famous physicians from the end of the 19th and early 20th centuries, Sir William Osler, he said, you know, to live a long and healthy life, develop a chronic disease and take care of it. Again, if we had time, I would talk about the amazing data from Sweden, looking at type 2 diabetes outcomes from Rashani and his colleagues. Really, again, seeing what's possible, that with good care, how well people can do. Now, the last point I want to mention is about this issue of addressing discouragement. That we want to make it easier for people to be successful. And that means plans, make sure people have plans for actions that are doable and realistic. We don't want to overwhelm people with too much. We also want to focus on the behavior, not the outcome, right? So we want to focus on not, you're going to lose 20 pounds before I see you next, but it's what are those initial actions you're going to take? And we always want to, as best as possible, people will be more successful if we focus on behaviors to start, not behaviors to stop. People will be much more successful if we think about focusing on, you know, maybe you're someone who tends to overeat at night, but it's not just how are you going to stop overeating at night? What are you going to start doing? Maybe having an earlier evening snack that will make it possible for you to be able to be successful with your effort to stop late night binging. And then we end with collaborative agreement and commitment. So before my patient walks out of the room, I want to say something like this, which is at the bottom of the slide. So just to make sure we're on the same page, can you tell me what's that one diabetes related action you're aiming to do over the next few months, whenever we're going to see each other again? Let's focus on just one thing, or maybe two things, but no more than that, one thing. And let's make sure it's clear. And if you can repeat it back to me, then I'm sure that's more likely going to happen, and you're more likely to be committed to doing it because it's so clear. And I want to underscore the one thing. It's one step at a time that can help our patients be successful. So we've talked about a bunch of strategies. Here's what we talked about: the importance of taking a few minutes just to kindly ask or assess what's driving you crazy about diabetes. Respond with empathy, making the invisible visible, like using a scorecard format of some sort and how we talk about it with our patients. Sharing the good news that with good care and effort, odds are good you can live a long and healthy life with this disease. And really address the discouragement our patients feel by making sure they're leaving us with action plans that matter. For interested in learning more about this, by the way, I want to highlight just two things. One is one of my favorite articles is from our friend, Dr. Al-Zaid, who's from Saudi Arabia and from the UK. Wonderful article he wrote a few years ago called "There's a Missing Ingredient in Diabetes Care Today," that really highlights a lot of the things that we've talked about here. And also at our institute, the Behavioral Diabetes Institute, we have a whole video series that look more in detail at a lot of the psychological issues that our patients with diabetes face and what to do about them, that are available for you as well at no cost. So just to let you know, they're here at our website, behavioraldiabetes.org. So thanks for listening. Appreciate it.